I'm here today with Dr. Pam Popper, who is the founder and president of the Wellness Forum. And if you've not ever been there or gone to her online courses, oh my God, she's amazing. And every woman should have to take her women's health course. Seriously, I learned so much. Oh my gosh. She serves on the Physician Steering Committee. She's on the President's Board for the Physicians Committee for Responsible Medicine in Washington, D.C. She served as part of Dr. T. Colin Campbell's teaching staff at Cornell University. She's included in a slew of documentaries, including Processed People, Making a Killing, Forks Over Knives, Food Choices, The Yo-Yo Effect, and she's written several books. My favorite, Food Over Medicine, The Conversation That Can Save Your Life, and most recently, Solving America's Healthcare Crisis. So important. My first question is, do you ever sleep?
Not a lot. I'll just tell you something kind of funny. For years, I've always been like a not long sleeper. And people would tell me, oh my gosh, you're gonna hurt yourself. Adults need sleep. Don't you know adults should sleep 7 to 8 hours? You're so careful about everything else. Well, I'll tell you, I found in a used bookstore, this is kind of an interesting story, a book that was written by the doctor who set up Mayo Clinic sleep clinic before they started drugging everybody. And it's a really good book on sleep. No More Sleepless Nights. And he talked about in the book that there are short sleepers and long sleepers and medium sleepers. And I'm a short sleeper, and it has nothing to do with intellect. Like Albert Einstein was a long sleeper and Thomas Edison, short sleeper. So you take a short sleeper like me and you try to get them to sleep 7 or 8 hours, and they can eventually do it, but they don't get rested. You take the long sleeper like Einstein, you try to let him sleep 4 hours and he's a zombie. So there is no prescribed amount of sleep for adult humans. I've been vindicated. I am doing just fine on 4 hours of sleep a night.
Wow. 4 hours? That's what you average.
Yeah. I bounce out of bed. Here I am. I've been at it since 5 in the morning and I'm raring to go.
Wow. Well, thank you. I know you have an incredibly busy schedule. So, wow. You're going to get that phone call that changes your life.
Yes.
You're diagnosed with cancer. You're stunned, frightened, overwhelmed, depressed. And these are just a few of the emotions that you're going to be going through as you learn about cancer. And in spite of this mental and emotional turmoil that you're going through, you've got to make some seriously important decisions. Right. So let's start at the basics. What is cancer?
Okay. Well, cancer, it's an interesting question to start with because we are unfortunately treating a lot of things that are not cancer. Okay, so lobular carcinoma in situ, ductal carcinoma in situ, thyroid nodules, this isn't cancer. All right, we treat it like cancer, but it's not cancer. Cancer is abnormal cell proliferation. These are cells that do not behave properly. They don't respire properly. They don't use energy properly. They build elaborate networks of blood vessels to feed themselves. They chew up glucose at 18 times the rate of a normal cell. They don't die when they're supposed to. They live forever. And they crowd out, at some point in time, they start to crowd out cells that are needed for function, and they don't perform any function at all in the body. And so you end up with a tumor. Metastasized cancer is when a cell or 2 or 10 break off and travel around the body and set up distant site metastases. So you end up with bone cancer or brain cancer. You start out with breast cancer, you end up with cancer in some other places. So it's the scariest disease, as you mentioned. It's also one of the most preventable, which we should maybe talk about a little bit. But because it can be easily fatal, including due to treatment, it's important to not make decisions in that emotional state.
Absolutely. And it's so hard because you are on this emotional roller coaster, and it seems so overwhelming, especially because when you get on the medical treadmill, it's just absolutely insane. Go here, do this, take this, and there's no time. And I know there's a lot of different types of cancer out there, but today I just want to focus on one specific type, which is uterine cancer. What is it, and how common is this?
Well, unfortunately, I wish I could tell you that there's a cancer that is becoming less rather than more common, because even after you filter out all the diagnoses, things are clearly getting worse and not better. All right. Uterine cancer is like cancer of the lining of the uterus. It means that the uterine lining is thickening. That's the characteristic, that there's abnormal cell growth there. It is common, as are many reproductive disorders or cancers of women. It's usually due to hormonal imbalance. Women have high estrogen levels. And so the first thing people will say is, well, I'm postmenopause, no high estrogen levels for me. You'd be surprised how many women who are postmenopausal who have very high estrogen levels for a couple of reasons. One is that they're consuming dairy, which contains estrogen and estrogen metabolites. And another one, big contributor, is being overweight because your fat cells secrete hormones that are converted to estrogen in the bloodstream. So the same issue, high estrogen levels, that causes hot flashes and night sweats for women who are going through or on the other side of menopause, that's the same thing that can cause uterine cancer, or breast cancer or ovarian cancer. If you have to go get yourself some cancer, I'd rather see it be uterine than ovarian. The mortality rates are a little less heinous, but it's serious and you have to take it seriously.
Wow. So what would be some of the signs and symptoms of that?
Well, sometimes there aren't any. Just a regular pelvic exam shows it. And sometimes there's abnormal bleeding or cramping or bloating, things that let you know something isn't quite right. And then an exam shows that that's what you have.
Okay. So what are some of the risk factors for uterine cancer?
Well, it's the same risk factors as the risk factors for everything else. In other words, here, we talk about genes a lot, and genes are not the primary determinant of health. They aren't. However, genetic predisposition determines what flavor of disease you're going to get if you misbehave. All right. So I misbehave and I'm going to get rheumatoid arthritis. Women in my family almost always get it. Somebody else misbehaves, type 2 diabetes. Somebody else misbehaves, uterine cancer or some other type of
Well,
cancer.
I mean, because my mother had uterine cancer. I mean, so does that mean I'm going to get it?
No, and this is the interesting thing about genes. If you have a great genetic profile, somebody who says, you know what, everybody in my family lives to be 100, and so I'm going to too. You can override that great genetic profile with enough bad habits that you become just like the rest of the population, overweight and sick. On the other hand, you can have the worst genetic profile in the world, and I think I have one. Obesity runs in my family, diabetes and heart disease run on my dad's side of the family, rheumatoid arthritis on my mother's side of the family. You can override all of that by good behavior. All right. So you end up with a certain risk factor when you're born, but you can change all of that for bad or good, either way, depending on what you do. But the specific risk factors for female reproductive cancers are eating a terrible diet, and most people do. And our definition of terrible is not optimal. In other words, a lot of people say, well, I'm doing pretty good. Well, I don't know what pretty good means. That's one of those terms that, you can't really quantify it. But the people who think that they're doing better than the others because they don't eat fast food, that's not an optimal diet. All right. An optimal diet is plant-based, low-fat, high fiber. So eating an optimal diet, if you're not doing that, it's a risk factor. Another risk factor is having taken some type of hormone supplementation. Rather, it could be oral contraceptives and hormonal IUDs in your reproductive years. It could be HRT after menopause. Hormone dysregulation during your reproductive years, PMS, and anything that's hormonally related. Being overweight, which I mentioned before, specifically the intake of dairy products, anything that has altered your gut microbiome in any way, because that's where your immune system is housed.
And we're learning so much about how important the gut biome is. I mean, at this point, oh my gosh.
There's not a disease module I teach anymore that doesn't include at least a passing mention of it, and sometimes an entire module dedicated to it.
Well, did you see the article in the Cell magazine that was talking about the gut biome within the breast tissue?
Yeah, there are microbiomes everywhere. There's a microbiome in your eyes. All of our skin has a microbiome. Lungs, I mean, it's everywhere. We're just sitting in a soupy mass of bacteria. If we could magnify what I look like sitting in the mass of bacteria and viruses and everything else, it would be a pretty messy scene. All the germaphobes out there are probably, having hives right now. But
oh my gosh.
Yeah. So
what about if you never got pregnant? Would that also be a risk factor?
A small one, not a big one, not a big one at all. The more important things are diet, lifestyle habits, weight status, lack of exercise, poor sleep, just not being hydrated. I mean, there's a proper way for humans to be maintained. Just like there's a proper way for all creatures on the planet. I mean, I have a 14-pound house cat, 14-pound house cat. And if you don't feed cats exactly what they're supposed to eat, they die quickly. Okay, it takes longer to kill a human because we're bigger, but you can kill a little house cat in a matter of a couple, 3 weeks if you don't feed it the right food, if he doesn't drink enough water, and the whole 9 yards. Well, humans do the same things to themselves. So through all of this, these risk factors, if you have genetic predisposition to develop cancer, and you end up with some uterine cancer. Like I said, it's a lot less awful than some other types of cancer that you might get, particularly ovarian, but the origin is the same, really.
So, how would they diagnose if they have uterine cancer? I mean, is there a test to determine this?
Well, usually what happens is you observe this uterine thickening, then they'll biopsy and they'll determine how dedifferentiated the cells are. The more dedifferentiated the cell is, the more aggressive the cancer is. So differentiation refers to the fact that uterine cells know how to act like uterine cells and brain cells know how to act like brain cells. But the more amoeba-like they become, where they don't do anything, they just sit there and suck up glucose, the more dangerous they are. So they'll stage it. And then the place where I think we all have some agreement in terms of what to do is to take the uterus out in most cases.
Right.
That's usually recommended. Where we start to get into, I think we should give a lot of thought to it, is when they start suggesting that you take out the ovaries at the same time. One of the reasons for that is because ovarian cancer is hard to find early, so we'll just take them out. You don't have to worry about it. But the same problems, their habits and every risk factors for ovarian cancer, for breast cancer, so you're going to take your breasts off. The same for pancreatic cancer. Well, how many body parts are you going to take out before you say enough already? So, the informed decision.
If you're taking the uterus out, okay, and you leave the ovaries, then are they still functioning? Are they still?
Yeah, your ovaries, they function differently. They're not releasing eggs in preparation for pregnancy, and they're not producing estrogen at the same level. But yes, they have a function. And I think we're way too cavalier about taking out body parts. And, just, we'll just get that while we're at it. You want to keep your ovaries. We have some very good data showing that women who have their ovaries taken out have a shorter lifespan than women who keep them.
Really?
Yeah. So I mean, if you have to take them out, that's one thing. But I would say probably 75 to 80% of the time, you don't have to take them out. You shouldn't take them out. It's worse if you do.
So what would be the chances that you had uterine and ovarian at the same time?
Probably not very, very strong. But if you have one type of cancer, you're at risk for all the rest of the types of cancer if you don't change your ways. And I think this should be the major wake-up call. You've got cancer. It's time to live your life differently. One of the things I say to people all the time, whatever you have, whether it's cancer or heart disease or diabetes or you're 150 pounds overweight, right now, the reason you're in this situation is that your life is set up perfectly to facilitate your current state of health. Okay? So if you're 150 pounds overweight, you are right now living a life that is perfectly organized to be obese. All right. So if you want to be not obese, you have to organize your life to live completely differently from the way that you're living right now in order to have that different outcome. And so, this is a wake-up call. And many people get lots of wake-up calls, by the way. What I've always found very interesting when I'm talking to people who are sick, seriously sick, cancer or something like that, is you'll hear something like this. Until this thing happened, I've led a healthy life. Things have been going great for me. And I try to be as respectful as I can. But I'll say to people, what part of the 75 extra pounds you're carrying and the chronic bladder infections and sinus infections and 5 or 6 antibiotics a year and the 3 DNCs and what part of this file, this thick, gave you the idea that you were doing great? And you know what people will say? It's kind of interesting. Well, everybody gets that stuff. Okay, well, everybody in a country where everybody's sick gets that stuff. But that's not normal. It is not normal for humans to be sick for most of their adult life, right?
Right.
So, yeah.
No, absolutely, for sure. But don't they have other things like to do an MRI or a CAT scan, things like that? Are those tools to use?
Yeah, it just depends. It depends on the person. It depends upon their weight status, their general health status. There's so many variables. I think the most important thing to focus on once you have a suspicion, even that you have cancer, is, and you mentioned this earlier, and I think it's a really important point. And you talked about, you've got to be clear-headed and make good decisions at a time when everybody's trying to herd you into things, okay? So you get that first devastating comment. It doesn't even have to be cancer. It can just be, we think you might do we have to look into this a little further? And people say, I can just feel my heart skip a beat, like the time stopped, let alone when they tell you it's cancer. So from that moment on, it takes an enormous amount of deep breathing, support from family and friends who aren't always real supportive when you make different choices.
Right.
To be able to say, look, I understand that I have a serious problem here, and I'm going to treat it seriously. But before I do anything, I'm going to look into everything. Okay. So, because I've seen recommendation for a CT scan, and there's no reason for it whatsoever. When the person went back and said to their doctor, why do I need this again? And well, we just like to make sure we're covering all the bases. Well, if there's serious, you're a cancer patient. CT scans increase your risk of cancer. You better have a really good reason for having another one of these, okay?
I know, don't these diagnostic tools have consequences?
They all medical intervention has consequences. All right. So here's where you want to basically start saying to doctors when they recommend things to you. Great idea. Tell me why I should do this. If you have evidence to show me that I should do this instead of that, whatever, let me see it. And then I'll be getting back to you, excuse me, to let you know what my decision is going to be. And the hardest thing, and particularly when you get to how much are you going to take out with surgery, or are you going to have surgery? Surgery is not always the answer here. How much follow-up treatment are you going to get? And all that sort of thing. This is when everybody in your life starts getting apoplectic, starting with doctors. Don't you understand? You're a cancer patient, and family members who say, your doctor is the head of oncology at the XYZ University Medical Center. He or she knows best. You should be doing what you're told. And the worst thing you can do is to do what you're told. And I'll put this in perspective for you that I think this is really important. So let's take a type 2 diabetic. I want to use an analogy to tell you where I'm going with this. So a type 2 diabetic comes to an event here at Wellness Forum Health, listens to everything whoever the presenter has to say, and says, you know what? I really like eating cheeseburgers and French fries. I'm not ready to adopt a different diet and exercise and lose weight and get rid of this diabetes. So I'm just going to keep doing that. And then a year later says, boy, that was a big mistake. And I'm now going to go back to Wellness Forum Health. In all likelihood, the odds are strongly in favor of this person still getting well. All right. When you're a cancer patient and you make the wrong decision, it may be fatal. You don't get a do-over. Because if the treatment you signed up for doesn't extend your life by a day, or it hurts you more than it helps you, you end up with more aggressive cancer and in a weaker state than you've ever been, much less likely to be able to fight the cancer. This could be the thing that you're undoing. So it is so incredibly important for cancer patients to know now instead of later, because the average cancer patient starts becoming incredibly open-minded, and so do the family and friends. When the treatment isn't working, that's not the time to be open-minded. It's before you start down the path. And let me give you an example. Avastin was approved originally for the treatment of colon cancer. It's not particularly effective. But when Fran von Eschelbach was head of the FDA, he signed an order approving it for the treatment of breast cancer. All right, it costs $100,000. It doesn't extend the life of a breast cancer patient by a single day. It shrinks tumors, but not a single day. Now let me tell you who benefited from this. The day that he signed that order, stock in Genentech went up about $6 billion. So Genentech did great. The cancer patients, not so much. Now, I'm going to add another dimension to this that's very important. So think about it. You're a cancer patient. You signed up for a treatment that costs a lot of money that doesn't extend your life at all. Everybody's insurance plans today have copays, and thank God they do. Our insurance premiums would be $25 million a year. I mean, with bills like that, right? So you and your family now have a copay of maybe 20 grand to do this that doesn't help you at all, right? And then, of course, where are you at the end of this? You haven't extended your life by a day. These drugs are very powerful and have a lot of side effects and weaken the body.
Very toxic.
Yeah. So you're in debt, and you're not better. You're in fact worse. Okay, so that's what you don't want to have happen. That's why it's so important to look before. I was talking to a member of ours not too long ago who has pancreatic cancer, and her doctor was all geeked up about this treatment after the surgery. And we looked at and she said, I need to see studies showing the outcomes for this, for this particular treatment. So he gave them to her. He was very nice about it. Gave her the treatment. So here's what the study said. If you're pancreatic cancer and you do nothing, of course, the assumption is always do nothing or do this treatment, which it doesn't have to be nothing or the treatment. You and I know some other things to do for cancer patients, right? The bottom line, you do nothing, you live for 25 months, and you do the treatment, you live for 27.5 months, 2.5 months. She said, I don't want to live for 25 months or 27.5 months. I want to live for 45 more years. Okay, well, nothing isn't a plan, is not a plan for 45 more years of life. And this treatment is not a plan for 45 more years of life. So ultimately, the person with the cancer has to decide, but it's good to know that before you start down the path of doing that particular treatment. Okay.
So what are the stages of uterine cancer?
Well, you have all kinds of, it depends on what staging system you're using, but what you're really looking for, the terms that everybody who's watching this will understand, you're looking for how differentiated are these cells? How aggressive is this cancer? Mm-hmm. You're looking for, has it metastasized? Has it gone anywhere else? Has it invaded neighboring tissues? Is it invasive, first of all, and then has it migrated, second of all? Those are the things that determine what type of treatment will be recommended to you, okay? So there are a couple different ways that you can do it with tumor type. You can do it, so I think before we get into the alphabet soup, that might not be very meaningful. What you're really looking for is how aggressive is this thing? And has it gone anywhere outside of, like, it's contained in the uterus, not so bad. If it's invading other tissues, you've got a little bit of a bigger problem. And if you have metastases to the bone or to the lungs or something like that, you're in fairly serious trouble.
Now, can this be determined, the stages, can that be determined before you go in for surgery?
Oh, yeah, it's always determined before, because that'll determine what kind of surgery you're looking at. If it's surgically, if you can do something surgically, I've seen situations where chemotherapy is given in order to shrink the growth, in order to get clearer margins and that sort of thing. If it's invasive, they'll often do that just to get clear margins. And I'm not saying that that's a bad idea. Surgery, and let me say this about cancer too. In 1850, two magical things happened kind of close together. And one of them was we had the ability to use anesthesia to perform surgery. Now, that's a big game changer, because think about having a uterus taken out without any anesthesia, right? So this is a big deal.
Yeah, that is. That's a good one.
The second thing is that we had the ability to do surgery in a sterile antiseptic room. So you were no longer at risk of dreadful infection because some doctor who didn't know any better at the time was laying you on a table where he just operated on a horse and trying to do something without anesthesia. So
I mean, I think back to the Civil War. Oh my gosh!
It was a
how did anybody survive going through any of those treatments? Oh my gosh!
Right. So anyway, when that happened, we had the ability to remove anything localized, and we have always had good outcomes from localized contained cancer when you took it out. The place where we've made no progress, I mean zero, a couple of exceptions that I would say, is with cancer that has metastasized, cancer that's invasive, cancer that's more advanced. We're not doing any better at that than we ever did. And the death rate from those types of cancer has not changed. So that's where you have to be the most cautious, is when you start looking at how many body parts are we taking out, and what type of treatment are you recommending that I do, and what is the justification for the treatment, and please look at the outcomes data. Okay. And another thing that doctors will do is they'll throw out a lot of terms that sound impressive. It'll say, this drug shrinks tumors by 50% in 30 days. And you think, wow, that's great. Well, that's not what you're looking for. You're looking for, how long am I going to live? If it shrinks tumors by 50% for 30 days and your life expectancy is still a year, that's not so good. All right. Another thing that they'll do is they'll use relative rather than absolute numbers. They'll say, this particular treatment extend your life by 50%. And you say, oh, wow, give me that. And so the person looking at that cancer patient I was mentioning earlier, who's going to live, a year, now lives for 18 months. Well, 50% of a year is 6 months, right? So you got 18 months. So what they really should do is put this in terms that the cancer patient will always understand. You get 6 extra months of life. Do you want to sign up for this? Now, as if this is not enough, let me tell you something else that people need to be very careful of. Is cancer doctors, oncologists, are the only ones who are allowed to buy drugs wholesale and sell them retail in their office. It's called the chemotherapy concession. So the doctor actually makes more money administering chemotherapy in the office than he probably does getting reimbursed for office visits and that sort of thing.
You're kidding.
Now, yeah, I'm not kidding. And this is a bad idea. What it does is you put, I've said for years, here's the problem with medicine. We take good apples and we put them in a bad barrel. You know what happens when you put a good apple in a bad barrel? Because it's next to the bad apples, it spoils too, okay? So I think good people go into medicine for the right reasons, but you put them in enough compromising situations, they become bad people too. The doctors should be forced to disclose this to the patient. And it doesn't mean that all chemotherapy is bad. I'm not saying that either. It's a very individual decision. Your health, your value system, what else you're going to do in addition to the whole night, because you need a comprehensive plan. But at the very least, it's closed because it might influence the way that an individual would think about getting a particular treatment. Another thing I'll mention to you, the reason why it's so important to be informed. Studies consistently show that, and the most interesting one I ever saw that was done was one where there were oncologists and their specific patients interviewed. And here's what they asked. These patients had lung cancer, cancers that are definitely almost always fatal. And so the researchers said to the patients, you're getting treatment right now. What do you think is going to happen as a result of this treatment? Oh, I'm going to save my life. Then they would ask the oncologist who's treating that patient, what do you think is going to happen to this patient? And they'd say, well, only going to live for about a year. So the oncologist knows that the drugs aren't going to work, has not communicated that to the patient, who we call it drinking the medical Kool-Aid, has consumed the medical Kool-Aid and now is getting this treatment thinking that things are going to get better. And the reason why I'm focusing on this is that it doesn't matter if you have uterine cancer, breast cancer, pancreatic cancer, brain cancer, skin cancer, it doesn't matter what kind of cancer you have. These are the rules that govern the game. So whatever it is, you just really have to ask a lot of questions. And so let me talk for a minute, because I think this is really important. We've talked about the pressure that cancer patients get. You get swept into this treatment. The doctor says, okay, today is October 11th. We're going to do this on the 14th, and we're going to do this on the 23rd, and then you're going to have surgery on the 24th, and then you'll be back here on the 31st. And people are going, oh my gosh, your head just swirls, right? So deep breath. And in order to keep everybody from getting apoplectic, okay, when you say, not right now, you would say, because it's October 11th, here's what I want to do. I know I have cancer. I know it's serious. I have decisions to make. I want to make sure I make good ones. By November 10th, I'm going to have decided what I'm going to do, okay? I'm going to be looking at a lot of different options. And when I gather everything up, I'm going to show it to you so you can see it too. And I'll tell you what I'm thinking of doing, and I'll be interested in your input. November 10th is the day. Okay, so now people aren't going, oh my gosh, she's not going to do treatment. Everybody settles down, and even including the doctor. Because if you ask an oncologist, what will happen if I just take a little time to figure this out, say 3 weeks, maybe 4, and they'll go, well, that's okay. They back right off when you do that, almost all the time, unless you have a blockage or something, No, not a month. Not a month. In fact, if you had cancer right now today, October 11th, if they scheduled you for surgery before the end of October, I'd be flabbergasted. So it's not like most of the time they're trying to herd you into getting things done, but it isn't like you rushed right into surgery because they're so backed up anyway. So it's hard for them particularly when they say, okay, today's October 11th, let's plan the surgery for October 30th. Okay, so you're going to tell me 10 more days is life and death. If you're in that precarious a situation, probably you shouldn't be worrying about treatment and should be figuring out what you want to do to whoop it up for a few days here before the end. But that's not where most people are. All right. So anyway, you then look at everything individually and you say to yourself, this is or is not a good idea. And I'll tell you, we have some great data on what happens if you do just conventional therapy. It's often not so good. I've given you a couple of examples. But it's also not so good sometimes when you only do alternative therapy. The best outcomes I've seen are when people put the two together. So you perhaps have surgery, you don't do the follow-up chemo, and instead you fast at a fasting center and convert to a better diet, and decide to renew yourself spiritually. There are a lot of things that go into it. So those are the best outcomes.
Okay.
So if you make the right decisions, that's your best chance of living. And I don't know how many of your listeners are familiar with Kelly Turner's book, Radical Remission. Must read for cancer patients. Have to read it. Do you know about this book, by the way?
No, I have not heard. What's it called?
It's called Radical Remission. Kelly is a friend and colleague of mine. I originally met her when we did the New York premiere of Forks Over Knives. That's how I first met her. Anyway, she, for a variety of reasons, got interested in cancer, and she happened upon an interesting thing. Well, I mean, we've all known about it. She just did something about it, and that is that everybody knows cancer patients where the cancer just went away, or the treatment wasn't working and they decided to do something else and they lived. Well, anyway, there are a lot of case reports in medical journals, and if you ever read them, here's what they look like, and it's kind of astounding. So the doctor will say, my cancer patient, JW, came in and he had lung cancer. And so here's the picture of the lung cancer, and it was metastasized and it was terrible. And I thought the guy was going to live for 6 months. And instead, in 6 months, the cancer was gone. So here's the image. You can see the cancer is gone. Wow. That's it. Nothing. Nobody ever asks JW, what'd you do to make the cancer go away, right? So Kelly did a study of 1,000 cancer patients who lived way beyond their terminal diagnosis. Terminal cancer patients who outlived their diagnosis, some of them by 20, 30, 40 years, okay? To determine what they did. And it was very interesting because these people didn't know each other. So 1,000 people who didn't know each other collectively used 75 different strategies to survive. But the interesting thing is 1,000 people who didn't know each other all used the same 9 in common. And that's what her book is about. The 9 strategies that terminal cancer patients use that saves their life. Diet's the first chapter, and then there's the rest of it. One of them is that they really are in control of their health. Their doctors describe them as annoying. Okay?
What?
Annoying.
What?
Yeah. Well, because they ask questions and they often don't do what their doctors say, or they say, well, I'll do this, but not that. And so their doctors believe that they're annoying. They use combination treatments. They do a lot of different things. They follow their intuition. They take supplements and herbs. And most of them report that they feel that they got the cancer for a reason, and that if they could get in touch with that, they would be able to survive. So they do a lot of renewing their spiritual connections and their social connections and family ties, and dealing with stress, getting rid of negative emotions, that sort of thing. And there are several stories in the book that are quite inspirational. I think it's a great book for cancer patients to figure out how to live. And it's a great book for people who don't have cancer to figure out how to not get it. So I have all cancer patients read it. If their families read it, it's very helpful in getting the family to back off and give the cancer patient space, time, and support, which they need.
Wow. So what are the typical treatments?
Well, surgery, and that's where there's usually some agreement. I mean, I've never, except when it's not cancer. I mean, there's no reason we shouldn't even be talking about ductal carcinoma in situ as cancer. It's not cancer. But assuming it's really cancer, surgical excision is a good idea most of the time. Chemotherapy and radiation are the treatments. Everything else is considered alternative, including diet. So
let's back up, because some people might not know what chemotherapy or radiation is. So let's talk about those.
Okay, well, chemotherapy is the use of drugs, often administered intravenously, sometimes orally, that kill cancer cells, but they kill everything else too. They're very hard on the body. It's some of them are like mustard gas.
It's like you're poisoning the body.
Yeah, you are poisoning the body, hoping to get to the cancer. By the way, it's not always that chemotherapy is a bad idea. It's the indiscriminate use of it that's a bad idea. I have one member who used low-dose chemotherapy combined with fasting, which potentiates chemotherapy, to shrink her tumor so that it could be taken out, because it was all over the place and you couldn't really operate on it the way that it was because the margins weren't clear. And then, so she used a couple little doses of chemo combined with fasting, shrank it, had it taken out. That's a good example of how to use it constructively, as opposed to, 2 weeks after your surgery, start showing up and you're going to have chemotherapy for 16 weeks and then graduate to radiation, which radiation is just that. You target the area specifically, unlike chemotherapy, which is systemic. there were problems with radiation. It increases inflammation. Inflammation promotes cancer growth. So take a brain cancer patient, they're almost always treated with radiation, which increases inflammation. Then they prescribe steroids for the inflammation, and steroids increase glucose levels, and cancer cells love glucose. And so a lot of times that's how a treatment
it's a cycle.
Cycles around, and how the treatment ultimately kills the patient in some situations.
Oh my gosh.
Expensive. Yeah, some of the new immunotherapies cost $500,000.
Oh my gosh.
Expensive stuff. And you know what? We live in America. If there's a $500,000 treatment that actually cured somebody of cancer, I would say let the taxpayers pay for it. I'd be willing to pay. But we're talking about an enormous economic burden, and it's not helping people.
Right.
That's a whole different story.
Wow. What about hormone therapy? Is this another treatment that is used?
Yeah, for women, and well, women and men who have men for prostate cancer, women for breast, ovarian cancer, and tamoxifen is one, and then aromatase inhibitors. So remember when I said that fat cells will pump out hormones converted to estrogen in the bloodstream. So the enzyme that does that is aromatase. So an aromatase inhibitor would be like Arimidex, and there are quite a few of them out there that will back down estrogen. But there are better ways to do it. You can change the underlying physiology that is causing this to happen.
Wow.
Always treat the cause. Whatever is wrong with you, it doesn't matter if it's cancer or headaches. You get to the cause of it and treat it.
Well, that's and that's my analogy. That I use a lot as I'm coaching people. I've got a pretty good punch. And if I come up and punch you every day in the arm, you're gonna go, "Oh, doctor, my arm hurts." And if you just stop me punching you, the pain goes away. But what about moderation? But if I come up and only hit you 3 times a week, am I still going to cause issues? And that's kind of like what we're doing. We're not getting to the root cause of why. We're treating the symptoms.
I think there are a lot of problems. And so I'm very critical of doctors. They don't, for reasons I mentioned earlier, but this is what they're taught in medical school. They cannot really do a lot of creative things in a medical setting. They're subject to malpractice lawsuits and getting their jobs terminated. So it really is incumbent upon the patient to do the research and find out what's going on and change things, because doctors really can't do it. But
the patients go in there thinking that my doctor has been trained in this situation. He's going to know, or she's going to know everything. She's been trained in this. She's an expert. She knows exactly what it is. She knows the research. She's got my best interest at heart.
Well, that's not always the best interest at heart. I think is that part's right. But here's the thing. Let's think about the way we buy other things. Do you know anybody who's gotten in the car with a real estate agent and the first words out of their mouth were, "I am so stupid about real estate. I think I'll just let you tell me where to live. I mean, you know so much more about it than I do." Now, I'm not a real estate agent. And I don't know a lot about housing values and cost per square foot to build. But we all managed to find out enough about that to make a pretty significant purchase. I don't know about you, but when I bought the house I live in right now, it was like a ginormous investment. It still is. I consider it an enormous investment. So you just don't let other people tell you what to do. You listen to their advice, you check things out for yourself, and that sort of thing. So everybody wants a guru to tell them what to do. And when you have cancer, you're so terrified. What you really want is somebody in a white coat to tell you, "I got your back, I got you covered. Don't worry about it. I'll take care of everything." It's like music to your ears, but it's really very deceptive music to your ears, and don't fall for that. I have to share with you, this member told me something yesterday that was it blew my mind. So this woman has little children. She's been listening to me and a lot of other people, and she's become increasingly concerned about childhood vaccines. So she said to her doctor, "I need to talk to you about this, and I need for you to pay attention to my concerns." And she said the doctor could not have been nicer. So she said, "I need to know what you know. What kind of research have you done," the doctor, she's asking, "on childhood vaccines?" So here's what the doctor said back. A stunning admission, but I think it just says it all, and it applies to everything. She said, "I know what I was told in medical school. I believe in vaccines. I vaccinated my own children. I'll continue to do that, but I haven't done any research at all on vaccines." Think about that for a minute.
Wow.
Well, I mean, an incredible, honest admission. She gets an A for being honest. But that is the difference between what the assumption is. I don't think this woman's a bad doctor. I think she thinks she's a good doctor. But think about, again, I teach the analogy. So you go file your taxes this year, you have a new accountant, and you say, well, what do you know about the tax code? And the guy says, well, I believe in filling in all the little numbers, all right? I always make sure I don't leave any blocks blank. I kind of like get on the IRS website and noodle around, but I've never really studied the tax code much. I mean, you would never leave your financial records there. I mean, so again, the part of the problem in medicine, and it's just worse with cancer, is that people go about doing things in a very specific way when they make other types of decisions. What school you're going to send your kids to, I mean, all these things. And then they abandon all of that good judgment when they get inside of a medical center. They do it for a couple of reasons. They think they've been trained to think that they're not smart enough to understand this stuff. And I have never met anybody who wasn't smart enough to understand this stuff within a short period of time, actually. That's the first thing. And then they become intimidated by doctors who don't want to, who are disrespectful, or they just assume that, and you should never assume anything. You never. I mean, think about it again, analogy. Have you ever had somebody say, I'm not going to read this mortgage document. It's just too hard to understand. I sure hope I can afford this place. I mean, people don't do that. All right. I don't know about you.
I don't know. I have to say, I just got this insurance, this rider that was like 27 pages long, and I'm like, oh man, this is like Greek to me. I mean, you know.
Well, and I'll tell you what, if it's a rider that costs you $110 a year, you're not going to spend a lot of time on it. But I'll tell you what, when I signed a mortgage for a few $100,000, you're going to spend a lot of time on it. Okay.
Yes.
So it's proportional to the seriousness of the situation. I mean, I can afford to buy a bad coffee grinder. They're $11. All right. I can't really afford to buy a bad car for $40,000. All right. So I can hire somebody who doesn't do such a great job painting my front door. But I'll tell you what, to build an addition onto the back of my house, I better hire somebody who knows what the heck they're doing so it doesn't fall into the ground 3 years after they're done. So if you just look at it again, the proportion, the amount of time and attention, investment of energy and educating yourself is proportional to the issue. And back to our discussion of cancer, I can't think of a decision that is as important to this in anybody's entire lifespan. I hope I'll never have cancer, and I hope that you never have cancer. But and if we don't have cancer, and if we die at 100 or whenever, we will not have to make a decision like this. Every decision that we make will be less than this important, in my opinion. Okay,
I know. It's tough. This is a serious one. Okay, so
it is the thing.
We talked about chemotherapy, radiation, surgery, hormone replacement. Those are the typical treatments, but are there other options?
Yes. Yeah, I'll give you some examples. And I'll give you some happy stories of informed decision-making, and one that's really, really good, because this outcome could have been so terrible. So, and this was my first time I ever got involved with a cancer patient, and it was a great learning experience for me years and years ago. So years ago, when my business was tiny, I had a little 900 square foot office, had my own little entrance. I love this little place. Okay. So, because life was simple back then, and I'm still a pretty happy clam, but I'm in a great big place with a lot of humans now, a lot more things going on. But anyway, the guy that I was leasing space from was a chiropractor. His wife was his receptionist, and she developed a malignant neck tumor. It grew very quickly. The prognosis for people who have head and neck cancers is really terrible. I think it's like 5 years survival at 5 years, or 5% survival at 5 years, which is really terrible. Fortunately, this couple was pretty savvy, and they said, we're going to look at everything carefully. She put a team together. I was on her team. We found a resource that was really good, a researcher by the name of Dr. Ralph Moss in Pennsylvania, and we got a report from him on head and neck cancer. And we found out that doctors in Germany use a combination of hyperthermia to the lymph nodes and low-dose radiation with a nutrition protocol, and almost everybody lives. Just the opposite of here. As it turned out, one of these doctors in Germany that we talked to had trained a doctor in California to do this. So she went to California for 3 months. She's still alive today, 20 years later. And I meet her at Starbucks every year on the anniversary. So that's a happy ending with informed decision-making, because had she done what was being recommended to her at the time, she would have had about a 5% survival chance. 20 years later, here she is still alive. Got to raise her daughter and see her graduate from school and all the things that she lived for. So that's what happens when you make good decisions. Another one that I'll mention to you, and her story is in one of my books, Kate Podolsky, her family owns a restaurant that I go to, a great restaurant called Rutter's up in Port Clinton, where my summer place is. And she got chronic lymphocytic leukemia. Came out of the blue. She was a fitness trainer, lean, no reason to believe, of course, eating dairy, a lot of other things we've been talking about. So she'd been diagnosed with CLL, and they proposed chemotherapy, and she didn't want to do it, and ended up talking to me and changed her diet, ate her way out of CLL. And she's still cancer-free today. This happened in 2001 or 2, I think.
Right.
A long time ago. Here we are, 2018. So, and by the way, when that happened, we said you're going to be checked out with a doc every 30 days to see where your white cell count is. If it looks like it's going up, maybe you have a little bit of chemotherapy. But that's not what happened. First, it stood still for a while, and then it started receding, and it's just been gone for 17 years.
Wow.
So when you look around, it's amazing. And I'll tell you another story that I think is interesting. Is we had another person who had CLL who opted not to do the chemotherapy, did a lot of other things, diet and retreats and meditation and yoga. And he was one of those people, like in Kelly Turner's book, where he said, my life is so screwed up. I think probably I should focus on that, and that'll help me, which it did. Anyway, he had CLL, and he lived for 20 years past his diagnosis. He was quite older when he got it. So he lived to be 87 or something. And he had a couple of times a little tiny dose of chemotherapy. Like the CLL would start to get a little out of hand, and he'd back it down. He had a great oncologist who understood what he was doing and would give him a little juice, he used to call it. And he lived for quite a long time. And he lived with cancer. Okay, so one of the things that I think is going to happen, and we could do another show on this if you wanted to, but I think we're going to get to the place where some types of cancer become chronic conditions like type 1 diabetes. Nobody expects to get rid of type 1 diabetes, but many type 1 diabetics can live to be 100 if they do the right things. And I think that in some cases, we're so focused on getting rid of the cancer that we're not really focused on preserving the life of the patient. You might be able to live just fine with some cancer, with a little juice here and there and an optimal diet and all that sort of thing. And so I'm finding those kinds of stories equally exciting, where the cancer doesn't go away, but it doesn't kill you either.
Wow. So what are some of the ways, what's some of the alternatives? Like, I've heard about water fasting.
Yes, water fasting. And one of the reasons that works is because humans have historically had to live for long periods of time without food. So we're pretty good at doing it. Our cells are pretty resistant to damage as a result. In fact, they get a little bit stronger. It's like, hey, we better hunker down and do our thing because got to keep this human alive, through periods of starvation. Cancer cells are really vulnerable. They do not do well when there's not enough food or glucose. So that's one of the reasons when I mentioned the idea of a little bit of juice for chemotherapy, potentiate the chemotherapy. It's one of the reasons why fasting before chemotherapy works really well. So water-only fasting is helpful, and True North is the place that we've sent people. I mean, I probably sent a few hundred people out there. They keep threatening to name a building after me at some point. I don't think there's ever a time I don't have some folks fasting at True North. But they're starting to publish case studies of cancer that's gone into remission while they're there.
Well, it's in the British medical journals. They've gotten some of their studies done.
Yeah, I'm glad to see them getting the recognition they deserve. So fasting, dietary energy restriction, believe it or not, in some cases, a ketogenic diet. My colleague, Tom Seafried at Boston University, has patients who have had 12 to 14 months life expectancy, and he's kept them alive on a ketogenic diet for as long as 7.5 years. And so again, he's looking at this, how can we turn this into a chronic condition? So that's something that could work. And then there are heat therapy, hyperthermia. I just wrote a paper on this, by the way, the different types of hyperthermia and the evidence that shows that it is particularly effective, like fasting, in potentiating radiation or chemotherapy. So again, we don't want to throw the baby out with the bathwater. And sometimes what happens is people pick a camp. I'm in the alternative camp. I'm in the traditional camp. Again, the marrying of the two is what you want. So hyperthermia is an interesting treatment that works, and hyperthermia applied to specific body parts, like what saved my landlord's wife. And then there's hyperbaric oxygen therapy. Yoga, believe it or not, there are a few interesting articles about yoga. And I think because yoga works on the person, going back to Dr. Turner's research with the radical remission patients. So yoga and exercise, weight loss always lowers your risk of dying of cancer. And then there are herbs, turmeric. We have some good research on turmeric. There are 400 and some randomized studies on mistletoe, which is used in almost mistletoe. It's used in almost all cancer clinics in Germany. And not much can go wrong. So, and this is another thing too, when you're looking at treatments, particularly alternative treatments, sometimes we have limited evidence of efficacy, but not much can go wrong if you do it. So, you don't see a lot of people taken to the ER because they're taking some turmeric capsules. So not a whole, and it's anti-inflammatory. Inflammation promotes cancer growth, so anything anti-inflammatory is good for cancer patients. So
that's what mistletoe does? It's anti-inflammatory.
Turmeric is anti-inflammatory. Mistletoe actually works on the tumors, extends survival. So yeah.
Really? Wow.
Yeah. There are about, I think the last time I checked, green tea is another thing. A lot of the research with cancer has been done on nutrients in green tea, like polyphenols and catechins. But there's one, just by way of example, there are over 1,800 published articles, randomized controlled trials in medical journals right now on the effect of one nutrient, a polyphenol called EGCG, in green tea. So I would tell everybody, if you can get good stuff, we have our own tea farms in China. So if you can get good stuff like what we have, green tea is something that cancer patients should use too. So the number of alternatives is almost unlimited. And it really depends upon what type of cancer you have, which things make the most sense.
Well, would going to a whole food plant-based diet?
Oh, absolutely. Dietary change, absolutely. You're not going to get better unless you do that. By itself, it's probably not going to fix everything, but it's an important step in the right direction. And it will facilitate weight loss. And for most people, a plant-based diet is a reduction in calories, to the extent that calorie reduction definitely has a lot to do with recovery from cancer. So yeah, absolutely whole foods plant-based diet. Understand that all carbohydrate is converted to glucose when you eat it. Okay, so Pop-Tarts converted to glucose, broccoli converted to glucose. Now, I'm not saying Pop-Tarts and broccoli are equivalent, but if
I'm glad you cleared that up.
But by the same token, if what you're trying to do is starve cancer cells, eating broccoli and not bananas, for example, or not having cake, that's not going to accomplish your objective. So that's where water fasting might be helpful. Again, the key is, what kind of cancer do I have? What's my state of health? What's my age? What else do I have going on? What drugs am I taking? Okay, a diabetic, 80% of pancreatic cancer patients are diabetics at the time of diagnosis. Right. So if you're a diabetic, type 2 diabetic, taking metformin, you better solve that problem, or you've got almost no chance of survival. Right? Wow. If you have some forms of cancer. So what you do, one thing is to get away from this cookie cutter idea that no matter what kind of cancer you have, you convert to a plant-based diet, or you do surgery and then chemotherapy and radiation. You can get into just as much regimentation on the alternative side as you do on the traditional side, and neither are good. It's what is going on with you, and what do you need to do to address your cancer based on your state of health, your type of cancer, etc. And it's quite variable.
Okay, so what would you recommend for circling back to uterine cancer?
Well, it would depend. What does this person weigh? What is the age? What are the comorbidities?
Right.
What type of, here's another thing that has to go into this. What type of risk tolerance does the person have? Some people are risk takers. They can tolerate risk. Other people, I have people who make, I think, the choices I wouldn't make, and it turns out great. You know why? Because they think it's going to turn out great. That's a big part of it.
Right.
So I think the key is, and sometimes cancer patients will say to me, well, what would you do? And I tell them, you know what, it doesn't make any difference what I would do. because I'm not the one in the situation. It's your body, it's your choice. You're going to have to decide what you want to do here. And I'm not going to tell you what I would do because it doesn't matter.
So what are some of the tips that you can do to help reduce stress associated with from the phone call?
Well, I think the first thing is you have to stop. And it doesn't matter what kind of problem you have. Hysteria won't help it. Think about what's going on right now. I was watching right before, when I went home for lunch, I was watching the hurricane damage in Florida. Okay. So they're showing all these people, the car's upside down, and, 3 of the bedrooms upstairs have a tree in them, and we've got no electricity and the whole 9 yards. So just think about if everybody just stood in the front yard and screamed and hollered and cried and got hysterical and jumped up and down. I mean, that ain't going to help anything, right? So what do you do in these situations? And you can kind of see what's going on. The first responders are getting in there, and they're just kind of looking around and assessing. Okay, we're not going to start rebuilding a single house yet. We got to figure out what the heck's going on here. Okay, we got to find out first. It's a really good analogy, actually, as I think about it. So think about what would happen if the first responders arrive in the first neighborhood and they start rebuilding somebody's chimney, and you'd be going, "What the heck are you doing? I mean, have you checked for survivors yet? I mean, we can rebuild the chimney. We can start that next week for Christ." So the first thing you do is you look around, you kind of assess the situation, and you start talking to people and getting information. And those devastated areas down there, at some point in time, and if you watch this on the news every day, you'll see in about 2 weeks, they'll have figured out they'll got the survivors straightened around, and people will start getting back to their house, and they're going to have a plan. There will be a plan, okay? And the city officials and everybody will get on TV, and none of us watch enough TV to put it together, but if you were to watch all the little segments, you'd see that, okay, first thing we're going to do, we're going to rebuild this bridge over here, because we got to do this to get people in and out.
Right.
Then the next thing we're going to do is we're going to get the trees out of here, and so there's a plan. They don't just go running into the scene of devastation and everybody starts throwing stuff around and let's put this in a truck, because you can't fix devastation that way. If a cancer patient would just say, "This is bad news. The hurricane, there's a tree in my house. This is bad news. This is very bad news. I'm going to have to really think about and do the right things." Okay. Because think about, again, those hurricane survivors, if you stay in the house too long, you can inhale a bunch of stuff that makes you really sick, and you don't file your insurance claim on time. You can make all kinds of mistakes in the hurricane business that you pay for the rest of your life. Not fatal, but, not good.
Right.
So just let's assess, let's figure out, let's research, let's make a decision. You keep it on a short string, okay? I tell everybody, if I was talking to a cancer patient right now, I'd say, look, it's October 11th. If we're still talking about this on New Year's Day, we've let this go on way too long, all right?
Right.
But we don't have to figure this out by Friday. We just don't. We've got time, and let's take that time and figure it out so that when you start this, yeah, you're going to have trepidation. Of course, you're scared half to death. You have cancer. But you will have some confidence that you know what's going on with your body. You've made choices that you don't feel like you just got herded into something saying, "Gosh, I hope this is going to work out." And the outcomes are generally much better. That's the best advice. Deep breath. Take time. Look into it. Best
All right.
advice.
Well, Pam, as always, I learned so much from you. Oh my God, you are incredible. And I can't say enough about you and the Wellness Forum and all the courses. And every woman that's listening to this out there, you need to be taking her women's health course. Just Google Pam Popper women's health course and it will come up. Oh my gosh. Wow. So thank you again for taking time out of your very, very busy day, and I appreciate it.
Happy to do it. Thank you.
All right. Thank you. Bye-bye.
Bye.